Welcome to the NCLEX Review, where I help you review all the things you need to know for NCLEX. If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com. So let's talk about the cardiovascular system. So the first thing we're going to talk about is cardiac marker labs. And the first one we're going to talk about is CKMB, or creatinine kinase myocardial muscle. So what this is looking at is if the value is elevated, that means that there has been cardiac damage following an acute ischemic attack. This is usually around 18 hours after an acute ischemic attack. And the normal value is going to be 2 to 6 in males and 2 to 5 in females. The next one we're going to talk about is troponin. So troponin C, cardiac troponin 1, and cardiac troponin T. So troponin 1 is specifically has a high affinity for myocardial tissue. So that's troponin 1. It rises within 3 hours and persists up to 7 to 10 days after myocardial injury. Normal values are typically low, with troponin 1 being less than 0.3 and troponin T being less than 0.2. Next one we're going to talk about is myoglobin. So this is an oxygen-binding protein found in cardiac and muscle cells. The level rises within 2 hours after cellular death, with a rapid decline in the level after 7 hours. However, it is not cardiac specific. Now let's talk about B-type natriuretic peptide, or BNP. This is released in response to atrial and ventricular stretch. It serves as a marker for heart failure. The levels should be less than 100, and the higher the level, the more severe the heart failure. Let's talk about cardiac diagnostic procedures. So the first one is an electrocardiogram. So this is going to record electrical activity of the heart. It detects dysrhythmias, myocardial infarctions, and cardiac hypertrophy. Then we have something called a Holter monitor. So this is a monitor that the client will wear throughout the day over 24 hours or more, and it records the electrocardiogram tracing throughout the entire day. But the patient must avoid hot tubs, baths, and showers because, again, it is electrical. Then we have an echocardiography. This is like an ultrasound. It evaluates the structural and functional changes in the heart. There's something called an exercise electrocardiography test, or a stress test. This is done while the patient is on a treadmill. If the patient cannot tolerate the treadmill, testing the patient may be given with an IV medication called So they'll give this IV, the patient doesn't have to get on the treadmill. And it's important to note that the patient should be NPO for 3 to 6 hours before the procedure. And our nursing interventions include instructing the client to avoid smoking, alcohol, and caffeine before the procedure, as these can interfere with the. Then we have a myocardial nuclear perfusion imaging, or an MNPI. This is the use of radionucleotide techniques in scanning for cardiovascular assessment. And then we have a magnetic resonance imaging, or an MRI. And this is going to use radio waves, magnetic fields, and atomic nuclei. It provides information on chamber size, valve, and ventricular function and blood flow. And our nursing interventions include making sure all metal is removed and to assess for claustrophobia. And because this is using magnetic fields, it can actually pull the metal out of a patient. So we just need to make sure that they don't have metal in their body. All right, so the next one we're going to talk about is a cardiac catheterization. And this is an invasive procedure which inserts a catheter into the heart and surrounding vessels. Our nursing interventions include assessing for allergies to seafood. This is a big one. Iodine or radioplaque dyes. This is because when they're doing this, they inject a medication that
is similar to seafood, and iodine has the same kind of allergic reaction. If you're allergic to seafood, you'll have an allergic reaction to it. So we need to know that doesn't necessarily mean that they won't get this procedure, but they might need to be pre-medicated or something like that. We have to withhold solid foods for 6 to 8 hours. If the patient is taking metformin, it must be withheld for 24 hours because of the risk for lactic acidosis. Usually held for 48 after the procedure. Post-procedure monitor peripheral pulses, color, warmth, and sensation distal to the insertion site every 30 minutes for the first 2 hours. Apply a compress device or sandbag to the insertion site and monitor for bleeding. Keep the extremity extended for 4 to 6 hours. Maintain bed rest for 6 to 12 hours, and do not elevate the head of the bed more than 15 degrees. So let's talk about cardiovascular disease process. So some keywords to know are atherosclerosis. So this is the development of a fatty area throughout the arteries of the heart. Then we have angina pectoris. So this is a term used to describe chest pain in which the pain is not localized but may include the left arm area as well as the sensation of an inability to breathe and demise. Thrombus. This is a term used to describe a blood clot. Then we have a myocardial infarction. It is used to describe a complete arterial narrowing that does not allow for blood flow to take place. It's also described as a heart attack. Then we have thrombosis. This is the development of a thrombus or clot inside a vessel. And ischemia, which is a decreased supply of blood and oxygen to an area of tissue. So when we talk about angina, and again, this is a term used to describe chest pain in which the pain is not localized. So we can have stable, which is chest pain with exertion or activity relieved with rest or nitro. We can have unstable, which is chest pain that is unpredictable, may or may not be relieved with nitro. And variant or prismals is chest pain due to a coronary artery spasm, and it may occur at rest. So let's talk about a myocardial infarction. Signs and symptoms: patients are going to have chest pain and pressure, diaphoresis, dyspnea, anxiety. Females can present stating that they feel like they have indigestion, shoulder pain, or jaw pain. And one important thing we want to look for is EKG changes. In acute MI, you're going to see an ST elevation in localized leads. So if there's ST elevation, that is a big sign that it is a myocardial infarction. So our nursing interventions, we always want to remember our ABCs. So breathing, circulation, we're doing vital signs. They might need. We want to look at an EKG, but also those cardiac markers that we talked about, because that's going to tell us if there has been tissue death, specifically cardiac tissue death, depending on which marker we're looking at. And they may need nitroglycerin or morphine. Those are the treatments for heart attack. Let's talk about aortic aneurysm. So an aortic aneurysm is an abnormal dilation of the arterial wall. So there's like a bulging of the arterial wall caused by localized weakness and stretching in the medial layer of the wall of the aorta. We want to assess for the main kind of big problem with an aortic aneurysm is that it could burst. And that's any aneurysm, right? We're nervous it's going to burst and then they're going to have bleeding. Signs and symptoms we're looking for are pain, syncope or cyanosis, dyspnea and increased pulse. They might have hoarseness, difficulty swallowing because of the pressure from the aneurysm. All right, so let's talk peripheral artery disease versus coronary artery disease. So peripheral artery disease is a decreased blood flow to the lower extremities due to atherosclerosis. Our signs and symptoms are intermittent claudication, so they're going to present with muscle pain in their extremities. They could have hair loss. So typically we see this on the legs. You're looking from the knees down. They'll typically have some muscle pain, especially when they're moving, hair loss on their legs, decreased peripheral pulses, cool and dry skin, gangrene, thick nails, and ulcers. When we talk about coronary artery disease, this is going to be an obstruction or narrowing of a coronary artery due to atherosclerosis. So one is an obstruction of the coronary artery, and the thing that is nice is this is called coronary artery disease. You know it's the coronary arteries due to atherosclerosis, where the other one is called peripheral arterial disease. So you know that it's not the coronary arteries. So with coronary artery disease, these patients are going to have chest pain, palpitations, shortness of breath, syncope, fatigue, and a cough. Now let's talk about heart failure. Congestive heart failure. So there's two types. We're going to have left-sided heart failure and right-sided heart failure. And these are going to look different. So our left-sided heart failure, if we think about the way that the blood pumps through the heart, right? It comes in to our heart on the left side. It goes to our left atrium. So it goes our atrium, right? It comes in on the right side. And it goes into our right atrium down to our right ventricle. Then it goes over through the lungs where it gets oxygenated. And then it comes back into our left atrium, down into our left ventricle, where it is then shot up and pumps through the entire body. So if we have left-sided heart failure, that means that this side of the heart is not pumping adequately. It's failing. So what's going to happen? The blood is going to back up, and it's going to back up into the lungs. So our signs and symptoms for left-sided heart failure are going to be pulmonary congestion, shortness of breath, tachypnea, crackles, cough, and hypertension because it's being backed up into the lungs. So for right-sided heart failure, it is similar where we have our right side of our heart is failing. So it's not pumping adequately. So the blood is coming in from the body. Blood comes in from the body. And now it's backing up. It's not pumping adequately out. So where is it backing up to? It's backing up into the body. So we're going to see signs and symptoms of edema, jugular vein distension, because if you think about it, this is the vein that is going into that right atrium. We're going to see abdominal distension, weight gain, and hypertension. So our nursing interventions for both types of heart failure are going to be high Fowlers, supplemental oxygen, monitoring the output, fluid and sodium restriction, monitoring daily weights, monitor the number of pillows used to facilitate breathing while sleeping. All right, let's talk about valvular heart disease. So the first one is mitral stenosis. So this is a valvular tissue thickens and narrows the valve opening. It prevents blood from flowing from the left atrium to the left ventricle. Then we have mitral insufficiency. So this is a regurgitation. The valve is incompetent, preventing complete valve closure during systole. And then we have mitral valve prolapse, which the valve leaflets protrude into the left atrium during systole. So let's also talk about aortic stenosis versus aortic insufficiency. So with aortic stenosis, the valvular tissue thickens and narrows the valve opening, preventing blood flow from the left ventricle to the aorta. So this is the aorta. This is when it gets pumped into the body. It goes to the left ventricle into the aorta. So signs and symptoms, we're going to have dyspnea, angina, syncope on exertion, fatigue, orthopnea, paradoxical nocturnal dyspnea, and harsh systolic murmur. With aortic insufficiency, the valve is incompetent, preventing complete valve closure during diastole. Our symptoms are dyspnea, angina, tachypnea, fatigue, orthopnea, paroxysmal nocturnal dyspnea, a blowing decrescendo diastolic murmur. So again, these are key differences, right? We always want to remember the key differences. And valvular heart disease is repaired by a balloon valvuloplasty. So again, looking at these, there's a lot of similarities in how they present, right? But we want to look at the key differences. So to me, it's that murmur. So definitely memorize which type of murmur goes with which type of valvular heart disease. All valvular diseases are repaired by a balloon valvuloplasty, a mitral-annuloplasty, a commissurotomy or a valvotomy, and valve replacement means that the patient has to be on anticoagulants for the rest of their life. Again, this is a key point, important to know. All right, let's talk about cardiac tamponade. So this is a fluid accumulation in the pericardium. Signs and symptoms are a pulseless paradoxis, a high CVP, jugular vein distension with clear lungs, muffled heart sounds, low cardiac output, and a narrow pulse pressure. Remember, we talked about how to find the pulse pressure. You take the systolic blood pressure and you minus the diastolic blood pressure. Our nursing interventions are going to be IV fluids and a pericardiocentesis, where they suck the fluid out. Let's discuss cardiac inflammation. So there's some different types. So we have pericarditis, myocarditis, and endocarditis. So pericarditis is an acute inflammation of the pericardium. Signs and symptoms are a sharp, pleuuric chest pain that's worse during inspiration. Again, this is a key point. You may see this in a question, and you should be able to identify that is a symptom of pericarditis. Coughing, relieved when leaning forward, a pericardial friction rub, fever, fatigue, and acute pericarditis, you'll see an ST elevation in all leads. Our nursing interventions include high Fowlers. This is our priority. Pain meds, NSAIDs, antibiotics, and monitor for tamponade. So a pulseless paradox, JVD, narrowed pulse pressure, tachycardia, and muffled heart sounds. Then we have myocarditis. This is an acute or chronic inflammation of the myocardium. So the thing that's nice, it kind of tells you where this is. The pericardium is for pericarditis. Myocardium inflammation is myocarditis. So our signs and symptoms include fever, a pericardial friction rub, murmur. So again, there's a key. Signs and symptoms of chronic heart failure, or congestive heart failure, so fatigue, tachycardia, and chest pain. And our nursing interventions are assist to a seated position, oxygen if needed, periods of rest, avoid overexertion, pain meds, antidysrhythmics, and antibiotics. Then we have endocarditis. So this is an inflammation of the inner lining of the heart, or the endocardium. Kind of tells you in the name what area it is. So our signs and symptoms include fever, weight loss, fatigue, murmur, congestive heart failure, petechiae and splintering hemorrhages in the nail beds. So again, there's a key. And clubbing of the fingers. Signs and symptoms, rest, TED stockings, monitor for signs and symptoms of an emboli or thrombus, and antibiotics. Let's talk about cardiogenic shock. So this is the inability for the heart to pump blood adequately. Signs and symptoms include hypotension, tachycardia or a weak, thready pulse. Urine output is lower than 30 milliliters per hour. This is always a sign that something is wrong. That's never good. Cold, clammy skin, and disoriented. Then let's talk about deep vein thrombophlebitis. So our signs and symptoms include the patient presents as warm skin on the calf or groin pain with or without swelling. If a patient is saying that one calf is sore, so specifically one, it could be both, but typically it's one, and it's warm when you touch it and they're complaining of pain, that is a sign of a DVT. So risk factors include Virchow's triad. So decreased flow stasis, endothelial damage, and hypercoagulability state. Our nursing interventions include elevating the extremity above the level of the heart, avoid a pillow under the knees, do not massage the area because you can dislodge it. We want to apply anti-embolism stockings, measure the circumference of the thigh or calf, apply a warm, moist compress as needed. They're going to have antithrombolytics. We want to avoid prolonged sitting because the stasis of the blood is what can make it coagulate. Now let's talk about atrial fibrillation. So this increases the risk of a stroke due to increased risk of blood clots because the heart is, during atrial fibrillation, it's almost like fluttering. It's not like fully beating. So the blood is just pooling there and staying. It's not being pumped. And the stasis of blood is what can make blood clots. So our nursing intervention is the patient needs to be on anticoagulants. We monitor INR if on warfarin, monitor a change in heart rate, and monitor circulation. And just to clarify, this is the atrial part of the heart. So remember, we have our atrium up top and then our ventricle below. It's kind of like our right atrium, right ventricle, and then we have our left atrium and left ventricle in the heart. And then the blood gets pumped. It comes from the body into the right atrium, into the right ventricle. Then it gets pumped into the lungs, where it then goes into the left atrium, down to the left ventricle, and then out into the body. All right, so let's talk about percutaneous coronary interventions. So this is when a catheter is inserted into the femoral or radial vein and advanced into the pulmonary artery to obtain information about the structure and performance of the chambers, valves, and coronary circulation. The procedure will improve coronary artery patency and increase cardiac perfusion. However, there are some complications we need to look for, so thrombosis, a stent occlusion, a hematoma, and limb ischemia. Then lastly, mechanical valves. So when a patient has a mechanical valve, they'll need to be on anticoagulants for the rest of their life to avoid a thromboembolism. Let's talk about cardiac electrical activity. Different places in the heart that conduct electrical activity. So the first one is the SA node. This is the main pacemaker. It initiates every heartbeat, generates impulses 60 to 100 beats per minute. That is the normal. This is known as the pacemaker of them. When this isn't working properly, patients typically need a pacemaker. Then we have the AV node. This is a place that receives impulses from the SA node. If the SA node does not work, then the AV node will take over and sustain a heart rate of 40 to 60 beats per minute. And then we have the bundle of His. This separates into the left and right bundle branches. It's located in the ventricles, and it can act as the pacemaker of the heart if the SA node and AV node fail, and the heart rate will be between 20 to 40 beats per minute. So when we talk about a pacemaker, this is a device that provides an electrical stimulation to maintain a heart rate when the patient's SA node fails to provide a rhythm. You'll see a ventricular spike on an EKG that indicates a pacing stimulus. So it will look like you'll have your EKG strip, and then you'll just see like a line, and then you'll see like the next heart rate, and then a line, and that is the pacemaker. You'll see the spike before the P wave for atrial pacing and a spike before the QRS complex for ventricular pacing. So this one would be atrial. And if you were going to see a ventricular, it would be over here right before the QRS. So our nursing interventions are going to be vital signs are monitored and cardiac monitoring is done continuously. We monitor for dizziness and weakness or fatigue, report swelling, redness, or drainage, teach patient how to monitor their pulse and signs of a low battery. We want to inform them of no cell phone use over the site, over where the pacemaker is. They don't want to put their cell phone on top of it. We want to teach We want to teach them not to go for an MRI because we know the metal, right, can get pulled out during an MRI because it uses magnets. Microwaves are safe. It's just a rumor that you can't use microwaves with a pacemaker, so microwaves are fine. And we want to teach them to avoid heavy lifting after surgery. So let's talk about the vagal maneuver. So in order to have a patient do the vagal maneuver, you'll have them bear down. This is when you're like holding your breath, but then also trying to exhale. If you're ever on a plane and somebody says, try to pop your ears, it's that kind of maneuver. And this can be used to terminate a supraventricular tachydysrhythmia. So if a patient is in SVT, the first thing you can do is have them bear down, and sometimes that will pop them out of it. A cardioversion is a synchronized, and it has to be synchronized to the R wave if delivered on a T wave. It can lead to a lethal arrhythmia, so it has to be synchronized on the R wave. It is a counter shock to convert an undesired rhythm to a stable rhythm. And then we have defibrillation. This is an asynchronous counter shock, so this one does not have to be synchronized, that terminates pulseless ventricular tachycardia or ventricular fibrillation. So let's talk about cardiac rhythms. So first thing is determining the heart rate using a 6-second strip. So this method can be used to determine the heart rate for regular and irregular rhythms. When we are determining the atrial rate, we're counting the number of P waves in a 6-second strip, and then we're multiplying it by 10 because we know there's 60 seconds in a minute. If we want to find the ventricular rate, we count the number of R waves or QRS complexes in that 6-second strip, and we multiply that by 10. It's also important to know that there are 30 boxes in a 6-second strip, and timing should begin on the P wave or QRS and end exactly after 30 blocks, which is a 6-second strip. Let's talk about cardiac rhythms. So the first rhythm we're going to talk about is sinus bradycardia. And we can see that this is a 6-second cardiac strip. When we have a 6-second cardiac strip, we can take the amount of beats in that strip and multiply it by 10, and we'll get the beats per minute. So in this one, we find our QRS, and we have 1, 2, 3. So 3 times 10 equals 30. So this is showing 30 beats per minute, which would be sinus bradycardia. Anything less than 60 is a sinus bradycardia. We can also see that because we have a normal rhythm. So we have our P, our Q, our S, and then our T wave. So that is all normal. So it's sinus bradycardia. So again, our rhythm, our P wave and QRS is regular. Our heart rate, P waves and QRS complex, both less than 60 beats per minute. We said we had 30. Our P wave is consistent and one before each QRS. That's true, right? PR interval is 0.12 to 20 seconds and consistent, and our QRS is less than 0.12 seconds and consistent, so true. So the pathophysiology, we have a slow heart rate less than 60 beats per minute. This can arise from a normal pacemaker in the heart. It can be the SA node. It can just be slow resting heart rate, sometimes in athletes. Our P wave is normal and followed by a normal QRS and a T wave. So our assessment, we want to look at subjective and objective information. So objective, we're looking at, is there any syncope? Or subjective, we're looking at any syncope, dizziness, lightheadedness, chest pain, shortness of breath, exercise intolerance. These are things that the patient says they feel. Objective is what we can see. So decreased level of consciousness, cyanosis, peripheral edema, pulmonary vascular congestion, dyspnea, poor perfusion, and syncope. Our nursing diagnoses are going to include decreased cardiac output, risk for injury, risk for fluid volume overload. And our interventions, they may need atropine if symptomatic to raise up their heart rate. It would be given by an IV at 0.5 milligrams at 3 to 5 minutes apart for a total of 3 milligrams. Treatment is directed at the cause, which could include discontinuing meds, preventing vagal stimulation. And our treatment goals is for the client to remain syncope-free, to show a normal sinus rhythm and have them remain free of injury. So now let's talk about sinus tachycardia. So same thing we just talked about, we're looking at a 6-second strip. We can see all of the different waves. So we can see our P, our Q, our S, and our T. So that is normal. But when we look at our 6-second strip, we see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. And if we take 13 times 10, because we want to figure out how many beats per minute, and we know it's a 6-second strip, and 6 times 10 is 60 seconds, which is 1 minute. So we take our 13 times 10 equals 130 beats per minute. So we can see our P wave QRS is regular. Our heart rate is above 100 beats per minute. Our P wave is consistent, one before each QRS. Our PR interval is normal. Our QRS is normal. So the pathophysiology, so we see the elevated heart rate of 100 beats per minute or more. Causes could include shock, fever, stress, exercise, which would be normal, anxiety, pain, or stimulants. So again, subjective is what the patient says they feel. So I feel a racing heart, anxiety, chest pain. Objective is what, so decreased blood pressure or an increased heart rate. Our nursing diagnoses could include anxiety, risk for injury, knowledge deficit. And our interventions are going to be things like a calcium channel blocker, carbamazepine, digoxin, or beta blockers to help slow down that heart rate. Our treatment goals is for the client to have less anxiety, have decreased or absent chest pain, to them demonstrate understanding of how to decrease their heart rate. So this has to match up with whatever our diagnoses was. All right, so now let's talk about atrial fibrillation. So if we look at this heart rate, we can see that, first of all, our QRS. And our QRS is our ventricle. That kind of shows us our ventricle. So our QRS is not regular, right? The distance from here to here is different from here to here. So that's the first thing. Then if we look for our P wave and our T wave, it's not here, right? We just have this like fibrillation, we can call it. So this is atrial fibrillation. So again, our ventricle rhythm, our QRS is irregular. Our heart rate, the atrial, has multiple rapid impulses from many areas of the atria, resulting in the characteristics of a fibrillatory line. So that's talking about this. Ventricular usually responds at a heart rate of 120 to 200 beats per minute. So we can see the ventricle is beating. So P wave, no clear P wave, no clear PR interval. So our pathophysiology, the atria of the heart, so the top of the heart, we have our right atrium, our right ventricle, our left atrium, our left ventricle. So this top part, our atrium, is quivering and the blood is not being pumped out of the atria. So we know that when blood is stagnant in the heart like that, there is an increased risk of blood clots because the blood is pooling. The causes are usually hypertension, valvular, or ischemic, and other types of structural diseases. So again, subjective, the patient may say they feel their heart racing. You're going to see decreased blood pressure, increased pulse rate. We have some nursing diagnoses there, but our interventions are going to be Coumadin if the client has been in a rhythm greater than 48 hours. If it's unstable, they may need a cardioversion. It depends on the cause or durations. Clients can convert to a normal rhythm spontaneously within 24 hours. So we want to check if they're symptomatic. If not, there may not be much we can do. So we may have to do those cardioversions and the medications, things like that. All right, let's talk about atrial flutter. So again, we're seeing something similar where we have our QRS here. So we're seeing those beats. However, when we look at our P and our T, it's definitely irregular, right? You can't see those waves. And the main thing that you'll see in questions is they call this a sawtooth pattern. If you see that, that's atrial flutter. So our rhythm is irregular. Again, the distance between here and here is different than the distance from here to here. Heart rate greater than 100 beats per minute, no P wave, no PR interval, and a narrow QRS. So you can see this is narrow. So pathophysiology. Tachyarrhythmia is most often contained within the right atrium. It's defined on an EKG by a sawtooth pattern of flutter waves, has negative polarity in leads 2, 3, and VF. The assessment. So again, patient may say they feel chest pain or racing heart rate. You may see blood pressure decrease, loss of consciousness, mental status change, a regular fast heart rate. Our interventions for this are cardioversion, and treatment goals, big things are restoring sinus rhythm, preventing thromboembolic complications, minimizing adverse effects of the therapy. All right, so let's talk about preventricular contractions. So when we talk about, this is also called a PVC, and you can see them here and here. So the rhythm is irregular because we can see it kind of changes, right? Heart rate varies. You'll see a P wave. There will be a wide PR interval. So again, it's going to be here, okay, and here. And our QRS is going to be narrow, but very big. So this is our PR. Okay, pathophysiology. So extra abnormal heartbeats that begin in one of the ventricles. These extra beats disrupt your regular heart rhythm, causing the patient to feel a flip-flop or skipped beat in chest. It can be caused by hypoxia, low potassium, caffeine, and stress. Patients will say they feel their heart skipping a beat, anxiety, stressed. Some people may say, oh, I drank caffeine. You'll see decreased oxygen. You might see their potassium low. You might see a low blood pressure, heart rate less than 60 beats, or decreased level of consciousness. And the intervention is, again, a cardioversion. All right, so ventricular tachycardia. So you can see there's no QRS here, right? It's just this tachycardic rhythm that is irregular. We don't have a P wave. We have wide QRSs. Like, these are all really wide. And we can't identify a PR interval. So pathophysiology, so it's a type of regular and fast heart rate that arises from improper electrical activity in the ventricles of the heart. Ventricular tachycardia may turn into VFib and cardiac arrest. If it's sustained, the heart rate can be greater than 120 beats per minute, and it can last greater than 30. Non-sustained, a heart rate is greater than 120 beats per minute, but lasts less than 30 seconds. Assessment, subject might say, I feel almost dead. The client might not be able to talk. They might have shortness of breath, chest pain, dizziness, lightheadedness. You're going to see palpitations, cardiac arrest, heart rate of greater than 100 beats per minute. And our intervention is we can have them try to do a vasovagal maneuver, but if they have a pulse, and amiodarone. If they have no pulse, then they need immediate defibrillation. So let's talk about ventricular fibrillation. So again, we talked about, we have the atrium at the top, the ventricle at the bottom. So this is when now that ventricle is just fibrillating. It's not pumping, right? If we look at this rhythm, we really can't determine anything. There's no regularity, there's no heart rate, there's no P wave, there's no PR interval. We can't determine the QRS. So the pathophysiology is coordinated contractions of the ventriculomyocardium is replaced by a high-frequency disorganized excitation, resulting in the failure of the heart to pump the blood. Patient may say they feel short of breath, chest pain, dizziness, lightheadedness, nausea. You might see low blood pressure, fainting, cardiac arrest, and a heart rate of less than or greater than 100 beats per minute, and palpitations. Our interventions include defibrillation and CPR. So asystole, we have nothing. So pathophysiology, there's no electrical activity on the EKG monitor. Client's probably unconscious. You're not going to see a pulse. So our interventions, this is our high quality CPR. They might need epinephrine. The recommended dose is 1 milligram IV push every 3 to 5 minutes. Vasopressin, 40 units IV is acceptable in place of first or second dose of epinephrine. And defibrillation will not work for asystole. That is important to know. Then we have paroxysmal supraventricular tachycardia. So if we look at this, we have an irregular rhythm. Our heart rate is greater than 100 beats per minute. There's no T wave, no PR interval, and a wide QRS. Pathophysiology is the rapid heartbeat that develops when normal electrical impulses of the heart are disrupted, and this can convert to ventricular tachycardia. The patient may say they feel like they're going to faint, dizzy, or chest pain. We're going to see a rapid pulse and diaphoresis. Our interventions are adenosine, rapid push 6 milligrams, followed by 20 milliliters of normal saline, and the heart rate will stop. So first degree heart block. We can remember this if R is far from P. So we have our P wave here, Q, R, S, T. So we're looking at this distance. So rhythm is regular, heart rate is less than 60, normal P wave, PR interval greater than 0.2, and a wide QRS. So pathophysiology, the wiring of the heart is slowing to send electrical activities, but all of the signals are able to pass successfully. There's no electrical block, but rather a slowing or delay of the signal, and this usually does not cause a problem. Causes include enhanced vagal tone, acute myocardial infarction, myocarditis, electrical disturbances. Subjective, the patient may rarely show symptoms. You may see a slow pulse. Interventions, there's usually no medical intervention required. When we talk about second degree heart block, this is also called Morbitz type 1, Wenkebeck. We can remember this as further drop. So if we look at our P and our R distance, we can see that it gets bigger and bigger and bigger, and it will drop. So rhythm, increasingly prolonged, heart rate's normal, P wave normal, PR increases with each beat until the QRS drops. So we can see we're missing our QRS here. So the QRS drops every third or fourth block. Pathophysiology, so a progressive prolongation of the PR interval until eventually an atrial impulse is completely blocked. And when the atrial impulse is completely blocked, there will be a P wave without a QR complex. Patient will say, rarely do they show symptoms, they might be dizzy, you'll see a slow pulse, and interventions are atropine followed by a pacemaker. When we talk about second degree heart block or Morbitz type 2, we can remember this: if some P's don't get through, you'll have a Morbitz type 2. So we're going to see a QRS dropped in an unpredictable pattern. So we can see a QRS here dropped. Our PR is constant, same duration. P wave is normal. Heart rate's less than 60 beats per minute. Our rhythm for our atrium is regular, but our ventricular is irregular because, again, that's the QRS. Pathophysiology, usually the disease of distal conduction system. There is an intermittent non-conductive P wave without progressive prolongation of the PR interval and can progress to complete heart block. Patient might complain of fainting, dizziness, lightheadedness, chest pain, shortness of breath. You might see a slow pulse. And our interventions will be a pacemaker. So third degree heart block, complete heart block. So for this, our QRS will be present but not equal to the amount of P waves. And we can remember this as P and Q don't agree. So we can see our P wave here, and they're all kind of different distances. We'll see our PR interval is delayed. Our P wave is inconsistent, sometimes more than the QRS. So again, we can actually see 2 here. Rhythm is regular, and our heart rate is less than 60 beats per minute. So pathophysiology, there's no communication between the atrial and the ventricles, and there's diminished cardiac output. Patient may say they feel like they're going to faint, dizzy, lightheaded, chest pain, shortness of breath. You're going to see a low pulse. And our interventions include IV titrated dopamine drip followed by a pacemaker. And now a paced rhythm. So our regularity is irregular, heart rate varies, P wave is inconsistent more than QRS, PR release is delayed, QRS is present but not equal to the amount of P waves. So this is why we place a pacemaker. So the pathophysiology, we're going to see ventricle spikes on short duration, usually every 2 milliseconds. So you can see these right here. So those are our pacemaker in the EKG. And our interventions include clinical monitoring, telling them not to do an MRI because of the magnet, and there are certain ways we can turn it on and off. So first, let's talk about sinus tachycardia. So the rhythm is regular. The rate is going to be greater than 100 beats per minute. Our P waves, our sinus, they're normal. Our interval is 0.12 to 0.20, and QRS is around 10 seconds. For sinus tachycardia, you have a regular rhythm, right? It has that same kind of regular rhythm, but there's just a lot of them because it's beating fast. When it comes to sinus bradycardia, it is a slow rhythm. So we're looking at beats of 40 to 60 beats per minute. And there's no treatment unless symptomatic. So if they have low blood pressure and loss of consciousness. When we talk about supraventricular tachycardia, we're seeing again a very fast heart rate. The rhythm is normal. It's just beating really fast. But the P and T waves have now formed into one wave. The PR complex interval is not measurable, and the QRS is around 10 seconds. So this is an unstable rhythm. You'll see they may need a cardioversion. They may have a low blood pressure, loss of consciousness, or chest pain. And that's if they're unstable. So there's two types. We have unstable and then stable. You could see sedation. You can have them try that vagal maneuver we talked about earlier where they bear down, and they may need a bolus of adenosine. Then we have atrial flutter. So again, the rate is 250 to 400 beats per minute. The ventricular is beating normal, but it's less than the atrial. And again, that atrial is in a flutter. It's just fluttering. For the P wave, you're going to see a sawtooth pattern. This is a key. If you see in a question, it's saying you see a patient's rhythm that's in a sawtooth pattern, that is going to be atrial flutter. And it's important to know that to control the ventricular rate, they'll use dilazepam. A flutter less than 48 hours long, they'll need a cardioversion. And if it's greater than 48 hours long, they will anticoagulate before attempting the cardioversion. Then we have atrial fibrillation. So a key for this is the P wave is fibrillatory, and we're seeing a heart rhythm of 350 to 600 beats per minute in the atrial, and ventricular is going to be less than that. But again, that atrial is just fibrillating. So we want to control the rate first. So again, we're using that dilazepam, AFib less than 48 hours long, cardioversion or anticoagulation in AFib greater than 48 hours long. Again, anticoagulate before attempting cardioversion. And unstable AFib, we will cardiovert ASTAT. All right, so first degree heart block. So this is a regular rhythm. It's just going to depend on the underlying rhythm, how fast it's beating. If there are no symptoms, it requires no treatment. Then we have second degree heart block, type 1. And the atrial is beating regularly, but the ventricle is not. The atrial is going to beat at a rate that matches whatever the underlying rhythm is, but the ventricular will be less than that. You're going to see the PR lengthening progressively until QRS drops. And this is also called Weinkeback. And then second degree type 2 block, this is, again, atrial is beating at the underlying rhythm, ventricle less than atrial rate. Our sinus will be 2 to 3 P waves before each QRS. So again, these are the key things to know. Usually ventricular rate is slow. We can see strokes, atom syncope caused by suddenly slowing of the heartbeat, and treatment is usually a pacemaker. All right, so third degree heart block, again, atrial regular, ventricular regular. Atrial is the same as the underlying rhythm. Ventricular is going to be 40 to 60 beats per minute. Sinus P wave has no relationship with the QRS. P waves may be hidden. Atrial and ventricular beat independently of each other. Symptoms include hypotension, dyspnea, heart failure, chest pain, strokes, atom syncope, and treatment again is a pacemaker. Then we have ventricular tachycardia. So we're going to see 140 to 250 beats per minute. We're going to have an absent P wave, and the QRS is going to be wide. So if it's stable, we're going to do amiodarone bolus over 10 minutes once rhythm converts and amiodarone infusion. If this is unsuccessful, they'll need a cardioversion. If it's unstable, we'll sedate the patient, cardiovert, and maintain an infusion of amiodarone. Then we have premature ventricular contractions. These patients are going to be tachycardic. There may be no P wave before a premature QRS. It will be wide. For a client experiencing PVCs, we want to notify the healthcare provider if they complain of chest pain or if the PVCs increase in frequency, are multifocal, occur on a T wave, or occur in runs of ventricular tachycardia. Ventricular fibrillation, no rhythm, no rate, absent this. So if it's witnessed, them going down, we defibrillate. If it's unwitnessed, we do CPR for 2 minutes before initiating shock and BLS. And then asystole, again, no rate, no rhythm, P wave is absent, not measurable QRS. We have an absent QRS. So if we witness, again, defibrillate, unwitnessed CPR for 2 minutes before initiating shock and BLS.
If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com.